Alright, I'm going to be talking about adductor strains for my clinical pattern. An adductor strain is any kind of tear to the muscle fibers in the hip adductors, and you can find those in the muscle belly, in the anthesis, or in musculotendinous junctions. It's more common in men than women, and risk for adductor strains increases with age. An outcome tool that is commonly used to assess the adductor strains is the Copenhagen Hip and Groin Outcome Score, or HAGOS, which looks at pain in both of those regions. Alright. So these strains may occur after microtrauma or macrotrauma. It is more common that strains occur with macrotrauma, which might look like a sports injury, or movements that involve pivoting, skating, kicking, or rapid acceleration while running. Microtraumas are from more repetitive movements that occur over time, and will present initially as kind of chronic pain at that site. So things that will aggravate this strain is palpating along the injured muscle, hip adduction, and repetitive movements. Things that will be alleviating are rest and avoiding active or resisted hip adduction. The 24-hour pattern, you can expect that the pain will be less in the morning and increase throughout the day with use. If the patient is reporting pain at night that might be related to this, it is likely that the position they sleep in is aggravating. Alright, a systems review would be indicated just to rule out any kind of other options, and we'll kind of go through some of those later, just with the signs and symptoms indicating referral to a physician. Alright, so as far as precautions and contraindications for these strains, it's okay to attempt the full exam. You might expect just some pain with hip adduction, hip flexion, hip internal rotation, hip extension or knee flexion, range of motion, or the resistive testing, and so the exam might be limited by pain. Alright, and during the physical exam, you might see variations in gait as far as the patient avoiding hip adduction, flexion, internal rotation, extension, or knee flexion. Active movement testing, you will expect pain or limited active range of motion with those same motions, just depending on which adductor muscle is involved. And then with passive movement testing, you might expect pain or limited motion with hip adduction or even hip abduction, depending on the strain. With cut testing, you might expect strong and painful hip adductor cut testing for a grade 1 strain, weak and painful hip adductor cut testing for a grade 2 strain, and weak and painless hip adductor cut testing for a grade 3 strain. Accessory motion testing, if you just do anything that involves lateral distraction or push or glide at the hip, you may be a little limited due to the patient's pain. Neurodynamics are not indicated, and with palpation, you will expect tenderness with the deep palpation of with the involved adductor muscles, pain at the attachment sites, which could include the pectineal line of the pelvis, the body of the pubis, the inferior pubic ramus, the ischiopubic ramus, the ischiotuberosity, lesser trochanter of the femur, or the linear aspera of the femur. And if you have a grade 3 adductor strain, you may be able to actually palpate the defect in the muscle. Some differential diagnosis findings could be gracilis syndrome, iliopsoas strain or tear, stress fracture at the femoral neck or the pubic ramus, an acetabular labral tear, or snapping hip syndrome. As far as imaging, diagnostic ultrasound, MRI, or x-rays may be used. And then if you're finding the following patterns, you may want to consider referring to a physician, and those would be severe pain at the hip, but the patient's range of motion is normal, and that could indicate femoral head osteonecrosis. If the patient's pain is radiating to their lower abdomen and groin from the side and the back, and they are reporting cloudy, foul-smelling urine, and they are nauseous or report vomiting, that could indicate renal calculus. And finally, if there is tenderness at the bony landmarks, that can also be a sign of a tumor or a neoplasia. So just watch out for other symptoms involved with that, such as the risk factor of being older than 50, having a history of cancer, having constitutional symptoms, having pain at night, and just having new mass, pallor, reduced blood pressure. And then as far as surgical options, there are few. You can get a surgical reattachment that would be involved with a grade 3 strain, or a tenotomy may help someone who has more chronic issues with adductor strains. Thank you.